Well, it's probably not too difficult to assess pain. I mean, if someone's got a big hole in them, obviously they're going to be in a lot of pain. Where if someone's just got a little hole in them, then they're not going to be in very much pain. Or if someone's just broken a finger, it probably won't hurt very much, whereas if they've mushed the whole arm up, then obviously that's going to hurt quite a lot. You might have come across this kind of thinking, unfortunately, even in healthcare. And it's not true. Because the level of pain that patients experience is not well correlated with the level of tissue damage. Let's say that again. The amount of pain patients feel is not well correlated with the amount of tissue damage. In other words, someone can have a little bit of tissue damage and be experiencing an awful lot of pain. Conversely, someone could have a lot of tissue damage, what you might think to be significant injuries, but not feel that much pain. Having said that, patients with polytrauma who have been traumatised do have a lot of pain, typically extreme pain, often all over. But that doesn't negate the centrality of this message. We can't assess patients' pain by trying to correlate that with the amount of tissue damage. We can't impose what we perceive as our standards of pain on patients, because the amount of pain that patients feel is modulated by many, many factors, some of which we understand, others of which might not be apparent. So the need to take action, for example, can reduce pain. Feelings of control can reduce pain, but feelings of loss of control can increase pain. Emotional state can make a difference to the pain. If the patient's upset, the pain is likely to be worse. If the patient's under stress, the pain is likely to be worse. If the patient is anxious, the pain is likely to be worse. If the patient is expecting pain and has a fear of pain, that can make the pain worse. And the pain can be modulated by patients' previous experiences. And there's whole areas of physiology which relate to pain. Some of these are described as analgesic effects, and others are described as hyperalgesic effects. Now, an analgesic effect is a reduction in pain. Gesia means pain. So analgesia literally means without pain. So within the body there are analgesic mechanisms which can reduce the amount of pain that someone experiences. But conversely, there are also hyperalgesic effects in the body. Hyper means high, algesia means pain. So hyperalgesia means an increased amount of pain. So for example, if someone's got an inflamed area, that can be very painful, causing much more pain in response to a particular stimulus than you might expect. So for example, if you prod yourself in the arm or poke yourself in the ribs, it might not hurt. But if you imagine there was an inflamed area there, like you had some great horrible boil on your arm, and you just poked that with the same amount of hardness, then it would hurt an awful lot when the boil was there, but it wouldn't hurt when the boil wasn't there, because the boil is caused by probably staphylococcal infection. That's going to cause an inflammatory response, and the inflammatory response causes a hyperalgesia. So the amount of pain that a patient is experiencing can't be worked out, can't be predicted from our physical assessment of the injury that they are suffering from. And of course this is summed up in the quote from McCaffrey: pain is what the patient says it is, existing when they say it does. So patients are the only arbiters of their pain. Pain a patient has is the pain the patient says they have. We have to ask them what their pain is, and they tell us. That's the only reliable gauge of pain that we have. Now, having said that, there are some signs of pain, and I'm using the term signs advisedly here. If we think about clinical features, these can be divided into signs and symptoms. A symptom is something the patient describes to us, like I've got a funny feeling in my arm, or I've got a pain in my head. That is a symptom. Or I feel dizzy. That is a symptom. It's something the patient is experiencing, and they convey that information to us. But a sign is something that we detect with our senses, something we can see, something we can feel, or I guess something that we could smell. But in the case of pain, then the facial expression might indicate that the patient is in pain. Or patients in pain are often agitated, they're thrashing around, they can't keep still. Or conversely, with some pains, patients lie very still because movement will make the pain worse. So, for example, if a patient's got peritonitis, they don't want to move around because it's going to make the pain in their abdomen worse. Or if a patient's got pleuritic pain, if they've got pleurisy, that can reduce the movement of that part of the chest. And we can sometimes see that as a physical sign. And as well as that, pain in the short term is going to stimulate the sympathetic nervous system. And sympathetic stimulation can cause sweating, increased respiratory rate, increased pulse rate, increased blood pressure, and pallor, that is paleness, can be caused by peripheral vasoconstriction. Having said that patients in acute pain get sympathetic stimulation, therefore increasing heart rate and increasing blood pressure, patients in pain can also get vasovagal episodes. Vaso means vasodilatory, and vagus refers to the vagus nerve, which is a parasympathetic nerve. So patients who are in pain actually can faint with the pain. They can get vasovagal episodes and go bradycardic and hypotensive. So actually acute pain can cause hypertension, but it can also cause vasovagally induced hypotension and fainting. So you'd have to lie the patients down till the blood pressure comes back round a bit, otherwise they might go unconscious and start fitting, which wouldn't be good. So there are some physical signs of pain. We should look out for these, but the patient is the only ultimate arbiter of their own pain. And this gives rise to the idea of a pain thermometer. So we can say to the patient, imagine 0 is no pain whatsoever, and 10 is the worst pain that you could ever imagine feeling ever in your entire life. Where is your pain now on that scale of 0 to 10? And the patient can give you a number. They can say, well, my pain's 1 or 2 or 8 or whatever it is. They can tell you what the pain is. So 0 will be no pain at all, feeling fine. 10 would be the worst imaginable pain that a human being could experience. What number is your pain on just now as I'm asking you the question? Now, I know this is going to be subjective because it's just the patient's opinion, but that is the definition of pain. It's what the patient says it is. But as well as that, for an individual patient, if you communicate clearly with them, you can get them to do this consistently. They can consistently report on their pain because they know what it is. It's just that we have to get them to communicate it to us clearly. So we might say that the pain's 2 in the morning but goes up to 4 in the afternoon. That means the pain is worse for that patient, because if we can get these numbers consistent for the patient, this can give us patterns in the way that the patient experiences pain. And also it can help us to evaluate our treatments. So if the patient's got a broken leg and their pain is 9, and we put that broken leg in a splint, or we give it some traction or whatever it is, and that pain goes down to 4, then that's good. It shows that intervention has been effective. Or if someone's got a headache and their pain is level 4, and we give them 2 paracetamol and it goes down to level 2, that's good, because it means that our intervention has reduced the pain. And as well as that, we can tell the degree to which our intervention has reduced the pain. So if you can communicate clearly with the patients, get them to report using this scale consistently, it's a very useful thing for us in our assessment of patients' pain. Now, for children, if they can't really conceptualise 1 to 10, what we can have is charts with faces on it. So we could have a face that's really screwed up, a face that's a little bit screwed up, a face that's normal, or a face that's smiley, and get them to point to the one that they're feeling at that time. But again, it gives us some way to try and quantify what the patient is experiencing, because that tells us how much pain exists. Now, another very useful tool in assessing pain is called the PQRST of pain. Now, of course, everyone knows about PQRST because it's what we use to describe the stages of the electrocardiogram. PQRST. They don't stand for anything, they're arbitrary letters, but everyone knows PQRST. So if you're assessing pain, you can just sketch down PQRST and you can work through it. Now, the P stands for provoking factors. So we say to the patient, look, what makes the pain worse or what makes it better? Is it worse or better in a particular position? Is it worse or better because of the cold? Does the cold bring it on? Does the heat bring it on? Is it worse when you've got stress? Is it worse in the mornings? Is it worse overnight? What are the provoking factors? What makes it worse? And then does anything relieve it? So when you get this pain, does anything make it better? Does lifting your hand up make it better? Or does lying down make it better? So P, provoking factors. Now Q is the quality of the pain. What is the quality of the pain? So, for example, is it a deep pain? Is it a superficial pain? Is it crushing? Is it a sharp pain? Is it a constrictive, heavy pain? Is it a dull pain? Is it a gnawing pain? Is it a grinding pain? Is it a burning pain? Is it a tearing pain? How does the patient describe it? What is the quality of the pain? So P for provoking factors, Q for quality of the pain. R is for region and radiation. Where is the pain and where does it go? So it's not uncommon for a patient to say, well, the pain begins here and it goes somewhere else, because pain can be referred. It can radiate to different parts of the body. So, for example, a patient might have a pain in their lower back, round about L3, L4 or L4 or L5 in the lower lumbar vertebrae, and that pain may radiate down through their buttock, sometimes down the inside of their leg. And it might be a tingly pain or a sharp pain that radiates down through their legs. And it might be associated with pins and needles. If it's associated with pins and needles, that tells us it's probably related to some form of nerve compression. So all this can give us very useful clinical information. So region, where is the pain and where does it radiate to? Now S is for severity and intensity on a pain rating scale. So again, what number is the pain? And ask about the numbers in different times and in different circumstances to try and give us more information on the severity and intensity of the pain. And T relates to times related to onset, duration and frequency. So when does the pain come on? How long does it stay on for? How long are the patients in pain for? And what is the frequency of the pain? So for example, a patient might have a migraine just before their menstrual periods. It might last for 24 hours if it's not treated, and they might get that every month or twice a month. So whatever it is, when does it come on? How long does it last for? And how frequently does the patient get the pain? So PQRST, a very useful way to assess more about your patient's pain. Now, I think the last thing I want to say about pain assessment is that we must advocate for our patients. We are our patients' representatives. They are currently unwell. Hopefully, we are not currently unwell. They have some mental or physical problem. Hopefully, we don't. So we advocate for them. And the guiding principle here is, how would I like to be treated in that situation? So if I was lying around on a trolley, in a corridor, outside an A&E department, with a broken leg, in pain, how would I like to be treated? And that is how we should treat our patients, as I would like to be treated myself. So we advocate for our patients. And, you know, the only safe thing, if we're unsure about pain, is to assume that it exists. So I've worked with elderly patients or confused patients or patients with psychiatric problems or learning disabilities who I strongly suspect have had pain but are unable to report that pain to me. In that case, the only safe thing is for me to assume they have pain and to take steps accordingly. Or some patients are just very stoical. They say they haven't got pain when actually I strongly suspect that they have got pain. Or patients might have had strokes and be aphasic or dysphasic. Aphasia means they can't speak. Dysphasia means they have difficulty in speaking. So again, I've got to work out ways to communicate with these patients to see if they are in pain. Or to think of even more extreme cases, patients might have persistent vegetative states, or patients might have locked-in syndrome. We really have to try hard to communicate with these patients to see if they are in pain. And if they are in pain, we can treat them. Even patients with spinal cord injuries can get pain, it's just that they can't feel it. So if a patient's got a spinal cord injury and they've got a pain lower down in their body below the lesion in the spinal cord, then they can get a condition called autonomic dysreflexia, which can cause all sorts of problems unless we recognise it and unless we treat it. Their blood pressure can become dangerously high. They can't tell you why, because they can't feel the pain, but there is a physiological effect on the body causing autonomic dysreflexia. Now, it used to be known that neonates couldn't feel pain. So newborn babies can't feel pain. There you go, they can't feel pain. Or that's what people used to think. And this is absolutely incredible. You know, nurses and doctors used to believe that neonates can't feel pain. Now, they base this on no information whatsoever. Just someone woke up one morning and said, I know, neonates can't feel pain. And the tragic thing is that this was acted on. So in this country, patients, neonates, babies, were operated on without general anaesthetic. They were just given muscle relaxants because clever nurses and doctors knew that neonates can't feel pain. The only problem, of course, was that they were wrong. Neonates can feel pain. They feel pain in exactly the same way as you and me. So just think about the grievous, hideous tortures that have been inflicted on babies by nurses and doctors out of pure arrogance. Pure arrogance. They believed that some patients don't feel pain, therefore we can treat them, we can do what we want to them, it doesn't matter, they don't feel pain. But they do feel pain. They were wrong. It's a hideous crime committed by probably several generations of nurses and doctors. Utterly inexcusable, so make sure you don't do it. Neonates do certainly feel pain. Children feel pain the same as we do, and therefore need analgesics just as we do. And in fact, we could take it further back. Fetuses in the third trimester certainly feel pain. If you stick a needle into them, they certainly don't like it, they back away from it. And physiologically, fetuses have an active central nervous system from 8 weeks after conception. That is well before the end of the first trimester. So to be safe, I think we should assume that fetuses feel pain and therefore treat them accordingly. So if you're unsure if a patient in your care is experiencing pain, the safe thing to do is treat them as if they were experiencing pain. I think that's better than a patient in my care having pain and me not treating that pain. Treating that pain. Treating that pain.